afternoon, everyone. I would like to welcome you all. Allow me first to congratulate my dear professor, Serag Zakaria, for this excellent meeting. And I am greatly thankful for his continuous support and encouragement. Our session today is in NAFLD and is in toward redefining to MAFLD. It's my pleasure to welcome my dear professors who are co-chairing this session and will reach the session by their valuable comments and their discussion. In alphabetical order, Professor Dina Ismail, Head of Internal Medicine Department, Bani Suef University, Professor Hara Farawila, Head of Clinical Pathology Department, Cairo University, Professor Khaled Hamida, Internal Medicine Hepatogastroenterology, Ain Shams University, Professor Rabab Fuad Omar, Head of Tropical Medicine, Cairo University, and for Professor Samia Ali, my sincere condolences for the death of her father yesterday, and may God have mercy on him. And Professor Sharif Migawil, Internal Medicine, Hepatogastroenterology, one of our eminent in liver transplantation, Cairo University, and Professor Wissam Ibrahim, Internal Medicine, Hepatogastroenterology, Consultant Clinical Nutrition, Ain Shams University. And I want to announce if you have any questions during the session, you can send it in the Q&A box and our eminent speaker will answer your query. And as we know, non-alcoholic fatty liver disease or NAFLD is a steatosis more than 5% in the hepatocyte after exclusion of alcohol, significant use that is by definition more than 20 grams per day in men and more than 30 grams in women, according to the ESEHG definition. And also after exclusion of other causes of steatosis, such as steatotic drugs or viral infections, for example, hepatitis C genotype 3. And actually, NAFLD is two distinct pathologic conditions, different prognosis. That is NAFLD or steatosis that is usually non-progressive, and NASH with the different spectrum of progressive fibrosis, cirrhosis, and hepatocellular carcinoma. Why we choose the NAFLD for this webinar? Because there is a high prevalence of the disease worldwide, affecting a quarter of the general population, with the highest prevalence, about 32% in the Middle East and South America. The lowest prevalence is in Africa, about 13.5%. Not only in adults, but also in children, there is increasing prevalence of NAFLD, reaching up to 7 to 10% in the general population. Those with metabolic risk factors, for example, diabetics, have a very high prevalence, more than doubling the risk, reaching about 68% in Europe and West Asia. The NASH patients has higher mortality than compared to the non-NASH patients, and the patients with NASH-associated HSC has the lowest survival compared to those with other causes. Also, there is growing transplantation for NASH patients and also growing transplantation for NASH-related HSC. There is increasing incident decompensated cirrhosis, HSC, and the liver-related deaths in the upcoming years caused by HSC. It is not only a hepatic disease, it is a multi-system disorder and is associated with increased risk of atherosclerotic cardiovascular disease, chronic kidney disease, and extrahepatic malignancy. ده الحقيقة النومنكليتشر of the NAFLD throughout the years ابتدى في الثمانينات by Ludwig called non-alcoholic steatohepatitis. 2020, an international expert panel putting a new definition at the metabolic dysfunction associated fatty liver disease. والحقيقة one of these, the lead of this group is Professor Mohamed Islam. Professor Mohamed Islam, it's my honor to welcome Professor Mohamed Islam, Associate Professor of Hepatic Medicine at Store Liver Center, Sydney University. He heads the Metabolism and Genomic Group at Store Liver Center, and also heads the International Liver Disease Consortium that led to the identification of genetic and epigenetic factors that impact hepatic steatosis, inflammation, and fibrosis. He led the international consensus for redefining of fatty liver disease. He undertakes basic and clinical research on hepatitis C, liver cancer, and hepatic fibrosis. He is on the editorial board of Liver International and World Journal of Hepatology. In his presentation, Professor Islam will outline the rationale and the requirement for the recent name change endorsed by the International Panel of Experts to metabolic associated fatty liver disease. He will discuss the conceptual framework for the change, the process for coming up with the name change through the Delphi process, and the implication of the name change for the daily clinical practice. In the second half of his talk, Professor Islam will discuss the new definition of MAFLD that should be the basis of clinical diagnosis, decision-making, and management, and how this will take the field forward to an era of the risk stratification for treatment. He will touch on some of the most recent data to be published on MAFLD using the new criteria. Professor Mohamed Islam, floor for you. Professor Mohamed.
Hello.
Hello, Mr. Mohamed. We are now we are hearing you. Please unmute your microphone, Professor Mohamed. Unmute your microphone.
Can you hear me now?
Yes.
Okay.
Your microphone is still unmuted.
I'm not really sure. It's sure for...
Yes.
Yeah. Can you hear me now?
Yes, of course.
Yeah. So, and then we give some of the new data, how this new from a concept to practice, then touch briefly on the future direction. So my only slide on the prevalence, as Professor Amin mentioned, MAFLD now is the most prevalent liver disease. So if you see this figure we published 2018 with Zubair Younesi, you can see the areas in red are the areas with the highest prevalence of MAFLD, and the Middle East has the highest prevalence worldwide. And then the pie chart on is a risk allele, PMPL3 polymorphism, which emphasizing the importance of gene-environment interaction when you consider the pathogenesis of MAFLD. On the other hand, a recent systematic review 2020 suggested that at least half or nearly half of the MAFLD population are non-obese, which again emphasizing the importance of consideration of metabolic dysfunction and metabolic health in any new definition for fatty liver disease. And as a reminder, as we all know, unfortunately to date, there is no drug for MAFLD. So what are the problems with the old name? Indeed, when we are talking about non-alcoholic fatty liver disease or NAFLD, it doesn't capture the heterogeneity of patient population with regard to drivers or disease modifiers. It doesn't, and subsequently, it doesn't define the individual subtypes precisely, which will allow for development of targeted therapies. And hence to date, all the inclusion for clinical trials are just based onto the histology, not the actual driver for the disease. And so it's not surprising at all that all trials to date either failed or just have a poor response, which is between 10 to 20% over the CO. And there is also a whole lot of problems from patient perspective, but I'm not going to go through it because my next speaker, Marco, is a leader on this field. So when you look for the heterogeneity, there is many factors you should consider. For example, age, sex, ethnicity, diet, alcohol, your gut microbiome, your background of genetic and epigenetics, and the least defined but the most important factor, which is the metabolic health. These factors are interacting very dynamically during the course of life, which is shaping the disease heterogeneity, leading to different subtypes, inter-individual variations, which will lead to variable natural history and, of course, variable response to therapy. So to illustrate this simply for our audience, think about 3 patients and 3 of these factors of the heterogeneity. So if you look for patient 1, for example, he or she's her major driver of the disease seems to be environmental factors, eating excess of fast foods, drinking excess soda with minimal or modest contribution for the genetic predisposition or metabolic health. In sharp contrast, when you look for patient 3, he seems to be eating healthy diet, undertaking physical exercise, have no or just one metabolic risk factor, but they are unfortunate because they're born with a high genetic predisposition with many or risk factors for the disease. For example, patient 2 can be a combination between the 2 situations. So why we care that much about the heterogeneity of the disease? Because it has a serious multi-scale impact. It affects animal models, and we know that there is no perfect animal model, and it won't be. But if we understand the heterogeneity, we can understand which animal model is suitable for which phenotype of the disease. Like, for example, high cholesterol can be suitable for lean NAFLD. High fat diet may be more for obese NAFLD. The other major implication is in the performance of clinical trials. As we just mentioned, we don't have a drug for MAFLD. All the trials to date are failed or showing suboptimal response with 10 to 20% over the placebo. And this is simply because these trials doesn't take into account the patient heterogeneity. And think about it, how it be more efficient if we can classify our patient according to the major driver of the disease, then apply a targeted therapy suitable for every patient according to the driver of his disease. The second problem with the old terminology, from a public health perspective, we all know that liver diseases are seriously underfunded. There is a lack of public health response. There is a lack of patient awareness. And for many experts, they believe that the major reason for this is this old name, which anything started by none, it means it's not important, not a starter. Like here, for example, a study from Chef Lazarus from Barcelona, 29 European countries, none of them have action plans for NAFLD. NAFLD was not considered in any of the guidelines of related disease like diabetes or obesity, and liver disease were found to be seriously underfunded. The third issue is that the whole concept of NAFLD as a diagnosis is based into the arbitrary threshold of alcohol intake. As Professor Amin mentioned, if you are below this one, you are classified as non-alcoholic. If you are above this threshold, you are classified as alcoholic. But in the reality, when you look, for example, in Australia, at least 2/3 of the population are drinking in moderate. Similarly, in US, similarly in many areas all over the world. In addition, there is emerging evidence that there is no safe limit for alcohol. For example, when you look for this mega study published in Lancet, more than 28 million individuals, any amount of alcohol drinking are associated with harm for human health. More specifically in patients with NAFLD, when you look in this large Korean study, about 60,000 subjects, even those who drink light or moderate drinking within the current definition of NAFLD are still have progression of fibrosis higher than those who are not drinking. So having all of this said, what do you think? What the audience think? Is the NAFLD the right name? So NAFLD is a diagnosis of exclusion. So it only exists when other diseases are excluded. We need to diagnose our disease using a positive criteria. So we acknowledge that it's a standalone disease, and it can and it does actually coexist with other liver diseases. And the combination of this disease will have a synergistic effect on outcomes. This point of special importance in areas like, for example, in the Middle East with high prevalence of viral hepatitis C, as well as MAFLD. Areas like China with high prevalence of hepatitis B, as well as MAFLD. Second, what is the safe limit of alcohol? There is no safe limit of alcohol. And the impact on lack of patient awareness, public health responses, underfunding. And the most important point, one size fits all doesn't seem to be working in clinical trial and is delaying our ability to reach for the first drug for MAFLD. So how we came up with a new name? Back in 2019, we put this concept in a small commentary published in Gastroenterology, and we make a framework for the fatty liver disease. And we said in the reality, you will find patients with metabolic predominant fatty liver disease and other group of patients with alcoholic predominant fatty liver disease. Yes, there will be some group of patients with a pure of these two phenotypes, but for the vast majority of patients may have some sort of overlap between the two conditions. Similarly, a very beautiful study from China found that even for between patients with NAFLD, there is a group of patients, their gut bacteria are producing alcohol into large amount, and is actually the cause for the fatty liver disease. So based on this concept, we call for a consensus, and in a second paper published early this year, we invited experts from all over the world, and we set a Delphi method. And in the first round, we make it open and ask every one of these experts, if you would like to call this name in the best you could, what are you going to call it? And we received between 25 to 30 suggestions. In the second round of vote, we asked the expert to vote on the top 6, and interestingly, over than 72% of the participants suggested MAFLD or metabolic dysfunction associated fatty liver disease as a more appropriate name to compare the old name NAFLD. But what others the general academic population think? So at least there are 3 Twitter posts today, one from Europe, one from US, one from Nature Review Gastroenterology, and into the 3 clearly MAFLD when compared to the old name. Okay, so we got now a new name which overcomes the limitation of the old name, but still the issue with the definition of the negative definition which link it with the NAFLD. So how can we define our disease? So in a second paper published in Journal of Hepatology, we set a simple algorithm for diagnosis of the disease. And please remember that the aim of this diagnostic criteria is not to be an academic complicated exercise, but to be a simple, practical, that any physician, even in a village, in a rural area, can apply this diagnostic criteria very simply by low resources and can diagnose the disease with high accuracy. We said, if you have a hepatic steatosis based on imaging technique, blood biomarker, liver histology, with one of the 3 criteria, if overweight or obesity, using ethnic cutoffs, or type 2 diabetes using international criteria, this meets the criteria of MAFLD directly. But what about the lean and normal weight? And if you remember from my first slide, I said that nearly half of the MAFLD population are non-obese. For those group of patients, we said they should have evidence of metabolic dysfunction. And at least 2 of these criteria can meet the diagnosis of MAFLD. And if you look for these criteria are all very simple, can be applied very easily, like waist circumference, blood pressure, lipid profile, pre-diabetes. The second aspect on this process of redefinition, one of the issues with MAFLD, with the development of the disease and development of cirrhosis, the steatosis tended to disappear. And it used to be called the cryptogenic cirrhosis. So we said that this term should be obsolete and we should define MAFLD-related cirrhosis. And we said a simple criteria for the diagnosis. So if your patient have past or present evidence of metabolic risk factors similar to my previous slide, plus documentation of MAFLD in a previous liver biopsy or in a previous liver hepatic imaging, then it meets the MAFLD cirrhosis. So for example, you see a patient today who is coming by cirrhosis. There is no obvious cause, but the patient in any time of his life meets the criteria of MAFLD. And you can see, for example, ultrasound 5 years ago, 10 years ago, with evidence of steatosis. This is enough to establish diagnosis of MAFLD-related cirrhosis. The third important implication of this new definition that we suggested we have to move out from the ridiculous false dichotomization into steatosis and NASH. And we accepted that this is like a highly movable between one condition and to others very easily and in a short time. And we said instead, patients should be considered having steatosis with lipotoxicity, and similar to other liver disease, we can score our patient into activity X and fibrosis Y. So all of this seems to be nice conceptual ideas, but does it work into the real life? So after the publication of this proposal, just a few months ago, at least 5 studies to date have tested this concept into a real world cohorts, and all of them consistently reached for the same conclusion that MAFLD diagnosis is more simple, more practical, easy to be applied, and more importantly, can identify patients at high risk, whether hepatic fibrosis or extrahepatic manifestation, more superiorly than the old definition. Like for example, this study by Lane et al. Using 13,000 from enhanced cohort, the same conclusion, MAFLD is more practical, can identify homogeneous group of patients, and is superior to NAFLD for identifying patients with fibrosis. Similarly, we have published recently with Professor Kawaguchi from Japan that the new diagnosis MAFLD can identify significant fibrosis 20% more than the old diagnosis, have higher sensitivity, higher specificity, higher negative predictive value. Even in patients with viral hepatitis, 2 studies to date, one from Egypt to Professor Yasser Fuad and Professor Dina Atiyah, they showed that the proposed criteria for MAFLD is well validated, easy applicable to the entire spectrum of the disease. Similarly, in chronic hepatitis B, a group from Hong Kong reached exactly to the same conclusion. And based on this evidence, we have recently updated the APASL guidelines and incorporated the new diagnosis for MAFLD. And you can find these guidelines, it's available as open access in Hepatology International. So based on this concept, what will be the future? At least there are 3 major implications for this finding. First of all, it will help into the disease subphenotyping. So if you look for this nice figure from Professor Fuad, so the term fatty liver were first used at 1845. In 1980, the term NAFLD and NASH was coined. In 2020, we suggested that MAFLD should be long-reaching umbrella term and we should abandon NASH. In the near future, what we will do, we'll have more stratification for our patient based on multiple factors, diet, genetics, epigenetic, metabolic health, which will allow us to have more personalized medicine for this group of patients. The second major implications, MAFLD is a systemic disease with extrahepatic manifestation. And in the reality, the main cause of this in patients of MAFLD is cardiovascular disease, not liver disease. So one of the implications of this new proposal that will allow for running multidisciplinary management for patients of MAFLD. So we can even see a joint clinics between diabetologist and the hepatologist, cardiologist, general practitioner, nephrologist, which definitely will improve the care of our patient because we will treat patient, not treating organ. The third important implication that with patient stratification, we will be able to, first of all, to include patients based on their major driver, not only on histology. We can tailor the therapy according to the type of the patient. And we can have a novel type of clinical trials. And we have suggested here in gastroenterology some of the novel designs of clinical trials. Like here, for example, you stratify your patient subtype 1, subtype 2, subtype 3. Then you choose the right treatment for every patient. So, Mr. Chairman, ladies and gentlemen, in conclusion, MAFLD is a prevalent disease. It affects 1 in 4 people globally, with the highest prevalence in the Middle East. There are a whole lot of problems with the old terminology. We came up with a new name through a consensus, and we came up with a hopefully workable definition. We have got an evidence of superiority of the new definition compared to the old one, and more importantly, the new definition and new name will get our disease in a firm, close camp with the other metabolic diseases like diabetes, cardiovascular disease, chronic kidney disease, obesity, which means that for patient, for clinician, for research, and for funding, this will be really very helpful. So our past is rich, our future looks bright, and the history of fatty liver disease is just beginning to be rewritten. And thank you for your attention.
Thank you very much, Professor Islam, for the elegant lecture and the expert discussion will be, we have a lot of questions about the new definition and what is behind for you, but we will postpone all the discussion. You will stay with us until the end because our co-chair have many questions for you. Now, this is your insight, well, the expert insight. Now, what about the patient perspective of redefining of fatty liver disease? It's a great pleasure to welcome Mr. Marco Korenjak from Slovenia, the president of the European Liver Patient Association, ILPA, to illustrate this issue. Mr. Marco.
So, hello, or I should say assalamu alaikum, which is a formidable greeting I like very much. We don't have something similar in Europe, so you just say hi or hello, how are you? But you say peace with you. So we will start with peace. Thank you very much for your kind invitation. A big praise to the wonderful chair, Professor Mona Amin, and of course, Professor Islam, who represented everything that was needed from the professional side. So I will just try to start my presentation. Okay. So I wanted to say first, before I begin, I'm the representative of patients. I'm the, as Professor Mona Amin said, I'm a current president of European Liver Patient Association. And in regards of the recent developments, I would like to start with the gratitude. Thank you for all that you are working in the COVID-19 era, because this is something that is very needed. And with that, I'm also very happy that we also spend some time together and discussing NAFLD and NASH. So my presentation will be from the patient side and how we saw this name change. So we had a discussion in the European Parliament in 2017, and one of our guest speakers was Professor Ajif Yalan. And when we spoke during the breaks, we noticed that NAFLD is something that is a name that causes more problems for patients. And we were searching for another name, but at that point, we just agreed on that name needs to be changed, and then everything stopped. But I'm very happy to know from Professor Islam's presentation that the steps were taken forward by a professional medical community, because I think in the name change, this should be done from the professional medical community and not from the patients. So my summary of the presentation. So I would like to speak something about the idea, where it come from, how to do the name change. What is the main problem for patients? What is the main message of the article that was recently published? I would like to share some of the data on the article that was published. And if we will have time, I will present our work as patient groups in Europe. So one of the management board at European Liver Patient Association is Professor Gamal, and we spoke many times about the problem of name and name change. And he also motivated me and other patient representatives to think about publishing a viewpoint from patient side regarding the problems that are connected and closely connected to this problem. So redefining the fatty liver disease from the patient perspective means that we want to tackle some of the issues. So one of the issue is confusion, one is stigma, one is low awareness, one is scarcity of holistic patient care. So if we just start with the first one, confusion. Confusion from both sides, from the side of the patient and from the side of medical expert. So some of the medical experts that are speaking about the disease to a patient are very well briefed and they know what they are speaking of. And we have many medical experts that are on a primary level. And if they see something like that, it comes also to a trivialization of the disease in regards of the patient. And if medical expert does this, it's the same for the patient. He will do the trivialization of the problem and he will make it smaller than it really is. So when we had a presentation in 2017 in European Parliament, it was really evident that with that name, so non-alcoholic fatty liver disease, we had a close connection to stigma. So we had a presentation of few patients that were diagnosed with NAFLD, of a patient who has been transplanted because of this condition. And they were talking about stigma and stigmatization from the environment they were in, and also about self-stigma. So they were not sure if this is something they caused themselves or this is something that happened because of the genetic things. So, and with NAFLD also, we can see a low awareness of the disease. As a patient, we can see this when we are communicating with doctors. And everything that I just said just leads to a poor access to health services. So, which again leads to poor quality of life and which leads ultimately to increased disease burden. So if we want to, or the change name has many positive effects. So one that I already spoke of is to reduce stigma. So, and then reduce trivialization, reduce confusion, improve health policy actions, increase public attention to the disease, which is now non-existent or very small. So we have a range of positive things that will come from the name change. For example, increase allocated funding, increase patient organizations that would be just for this, area. So we just published a viewpoint on that with leading author, Professor Gamal. And if you see the authors that were there, so there was a bunch of people that were discussing this from the viewpoint at every place in the world. So if we just look from the countries that were involved in discussing this, there was Belgium, UK, Egypt, USA, Slovenia, Spain, Guatemala, Finland, so Philippines, Mali, Switzerland, Macedonia, Georgia. So there were a lot of bunch of people that were representing patients and patient activities. And we were discussing what the name change would, how the impact would be on patients that are currently with that. So I did a small, just a small analysis prior to this talk. So where is about this article? So as you can see, this article was just published, but the attention is extremely, it goes extremely well. So at this moment, this article is at the top 5% of all research outputs that were tracked by this Almetric and are published in in this section. So we think that attention is really skyrocketing because here you have not so attention just from the medical experts, but also from the patients that are in the field and facing this, this problem. So despite of increased recognition as a major health threat, so fatty liver disease in general is still remain largely undiagnosed and undertreated. So we together say that it would be great to change the name. The name was carefully and very good selected through the Delphi method from the medical experts. And we do agree that this name that is different from the old name has a very, very selected and good benefits. So I would just conclude and end this presentation just to give you a brief overview of who we are and what we do. We were established in 2005. So we are promoting everything that has to do with patients with liver diseases. And we see that liver diseases and experts who are working with liver diseases, you included, are underrepresented regarding all other areas of medical research. So today we are of 32 members, so patient associations from 25 countries in Europe. We do three things. So we do member empowerment, how to better tackle the work as a patient representative. We do some policy and advocacy work at the European Parliament. And we had also discussion about the name change at the European Commission. So in January 2019, we were together with the Commissioner for Research, and we were discussing on how to set aside more funding for medical researchers that are in the field of liver research. And he said, or he assured us that in next research grants at the level of European Union, they will consider to change this. And we participate in scientific projects. So the scientific projects that we participate in are at the moment 7. And they are together, they account for 75 million euros that are spent on liver research. But when you look at everything that we are part of, you can see that we prepared like 4 different, together with medical experts, 4 different research projects for European Commission, and they were all rejected. So I think we have a lot of things to do there and a lot of space to do it now that the name change is here. So we do think that if we work together as patient community and medical experts, we are very strong. So when we go to the decision makers, we need your data, we need your professional opinion, and we need also our advocacy. And when you put this together, we can then really change things. And this is a great example with the name change of this disease. So with that, I would just say, shukran for your attention, and thank you very much for your kind invitation.
Thank you very much for your time and being with us today. Thank you. We will continue for another lecture, and we will open the discussion after this lecture with our commentators. What's new in NAFLD pathogenesis, biomarkers, and treatment? It's my honor to welcome Dr. Mayasem Wahid Akrouche from Jordan, consultant of gastroenterology and hepatology, MD, MRCP, FRCP from UK. Welcome, Dr. Mayasem. Dr. Mayasem. She's not here. Okay, we can now open the discussion from our commentator to our 2 speakers.
Ramona, can I ask Professor Islam if there is time for questions now?
Yes.
So, Professor Islam, I'd like to congratulate you for this, of course, the very scientific concept. And of course, this is a great achievement in the field of medicine and the field of hepatology. But I would like to ask you about, do you think that this new nomenclature will resolve the problem of inconsistency in guidelines between European and American and so on? And of course, following this will be another short question. Where would you define, or how are you going to define metabolic healthy obese in this new nomenclature? And again, thank you for this very great presentation.
Thank you, Professor Mudawar. It's 2 great questions. So first of all, the fact of some controversy between the 2 societies. And I think usually the controversy happens because when there is no definitive answer, And this has happened because we don't understand much about the disease and we don't have a treatment for it. But we are hoping that we know that this is just a starting point, and we are hoping with more subphenotyping for our patient, we can be able to reach for more definitive treatments and way of management. This will help to find more like a consistency between the societies. Regarding your second point, it's a great point. Yes, obesity can be classified as metabolic health obese or unhealthy obese, but as we mentioned in the Journal of Hepatology paper, metabolic healthy obese, they are still of a bit higher risk compared to the general population. And the second fact that this is just seem to be like a honeymoon period, and they can, over the time with the follow-up studies, they can shift to metabolic. So we thought that criteria of obesity, whether you are metabolically healthy or not, with evidence of steatosis, because this is another evidence of metabolic abnormality, which the fatty liver, then you should be diagnosed as MAFLD.
Okay, thank you.
Any question from the expert? Now Dr. Mayas is with us. We will continue for the next lecture. Who is not online yet? So we will proceed the next lecture until she can connect with us. In view of the new emerging drug development in the pipeline, fast identification of NASH progression is now urgently needed. Let me welcome my dear friend, Professor Carmen Ferrentino, MD, PhD from Carol Davila University of Medicine and Pharmacy, Bucharest, head of the gastroenterology department at the University Hospital Bucharest, vice president of Romanian Society of Internal Medicine, member of the ESEHG and American Gastroenterology Association Fellowship. Hi, my dear Carmen, now the floor for you.
Hello, I want to thank the organizer, and especially to my friend, Professor Mohamed, for inviting me to this very interesting and very prestigious webinar. My talk today is about the fast identification of NASH progression. This is my disclosure, and this is the outline of my presentation. It is important to remember that NAFLD covers a spectrum of lesions ranging from simple steatosis to a complex pattern, steatohepatitis or NASH. The diagnosis of NASH requires liver biopsy and is characterized by hepatocyte steatosis, lobular inflammation, and hepatocyte ballooning, the key diagnostic features of NASH. Can be also present a special type of fibrosis, pericellular fibrosis or chicken wire fibrosis. Only the NASH phenotype can progress to advanced liver disease, and it is associated with liver-related mortality. Although a substantial proportion of the population has NAFLD, about 25%, only a minority progresses to advanced liver disease, and it is a challenge for physicians to identify them within the large NAFLD population. This is a natural history of NASH over more than 40 studies. The patient with NASH, about 40–50% have fibrosis, and from them, about 20% will progress to advanced liver disease or cirrhosis in about 30 to 40 years. But there are 20% of patients that are fast progressors to cirrhosis. That means in 10 years. And it is another challenge for in the field to identify the patients who are rapid progressors to cirrhosis. This also NASH, it is a histological diagnosis and requires liver biopsy. Liver biopsy, because until now we don't have an ideal biomarker for NASH diagnosis instead of liver biopsy. Liver biopsy is necessary not only to confirm the diagnosis, but also to stage disease and to stratify the progression risk. But liver biopsy to classify such a large population is impractical. It is an invasive procedure with low but real risk of complications and also have sampling and reading variability. It is important to ask if you can identify patient at risk for progression to advanced liver disease without using liver biopsy. For this aim, we have to look to the metabolic or to the clinical profile of the patient, especially the presence of metabolic syndrome, because the metabolic syndrome is the strong predictor of NASH, and even more when there are many features of metabolic syndromes, there is a high risk for advanced disease. That is why ESEHG recommends for all patients with metabolic syndrome to be screened for NAFLD as a routine workup. And in high-risk individuals, such individuals aged more than 15 years or with comorbidity as metabolic syndrome, the evaluation of liver fibrosis, it is advisable. Let's talk about biochemistry in NASH. ALT and AST are not sensitive for NASH evaluation because ALT values can be normal in about 80% of patients with NAFLD and in about 50% of patients with NASH. And also, as you see in this table, there is no correlation between the ALT values, normal or abnormal, and the histologic severity of the liver disease. And also in the graph, you can see that there is a slight downtrend of ALT values if the disease progressed from mild to severe disease. In conclusion, we can say that ALT is not sensitive in assessing NAFLD or NASH. The fibrosis is the most important predictor of advanced liver disease in any chronic liver disease. And in a longitudinal study, enrolled about 619 patients, followed 12 years, the presence of fibrosis and no other histological feature, including NASH, was associated with the long-term overall mortality and also with liver-related mortality. Due to the limits of liver biopsy, in the last decade was a significant interest in developing the non-invasive markers for evaluation of liver fibrosis. And the most common dedicated for this disease are NAFLD fibrosis score and FIB4 score. As you see, they contain routine laboratory enzymes and parameters and demographic information. And also you can see that both score use two cutoffs value. It is the low cutoff, it's more sensitive, and it is used to rule out or to exclude advanced fibrosis, and because have a very good negative predictive value, and the high value predicts the high risk for advanced fibrosis, but due to the not so well positive predictive value, it is necessary to or required for confirmation liver biopsy. Also, you can see that between low cutoff and high cutoff, there is an area, gray area, where fibrosis cannot be determined. When we apply these scores, non-invasive score, NAFLD fibrosis score and the FIB-4 score lack sufficiently positive predictive value to be used alone for NASH, for evaluation of NASH and fibrosis. Let's talk about ultrasound or imaging biomarkers. FibroScan, it is an ultrasound device that is used for steatosis evaluation using control attenuation parameter or CAP, and also for measure the liver stiffness as estimating the liver fibrosis. Regarding the liver stiffness, this technique is more reliable in ruling out advanced fibrosis because negative predictive value is stronger than positive predictive value. Also, the high values of liver stiffness are correlated with the risk of decompensation and also are correlated with portal pressure. There is an overestimation of fibrosis in case of hepatitis, vascular congestion, and also of cholestasis. And that is why VCT or FibroScan lacks sufficient positive predictive value to be used alone to predict NASH and fibrosis. And once the patient with NAFLD were identified, there is additional challenge for selecting the subtype of patient with high risk for NASH and advanced fibrosis. We can use this approach that is based on clinical parameters, the age, and also the presence of comorbidities, and also can use the result of non-invasive tests of liver fibrosis. And using this approach, we can stratify the patient in the 3 grades of risk: low, intermediate, and high risk of NASH and fibrosis. We can rapidly stratify the patient with NAFLD by using this approach. For example, we consider that the patient it is included in high risk for NASH or fibrosis is a patient aged more than 15 with comorbidities, with VCTE more than 8.5 kPa, and also with high value of NAFLD fibrosis score or FIB-4 score. And now let's move on the diagnosis of NASH, of active NASH, and with the significance of advanced fibrosis. There are new non-invasive tests on development in this context. And as you see in this table, there are 4 new non-invasive tests: NIS4, FibroSpect, ADAPT Pro C3, and FAST. The majority of these tests are blood-based tests, and FAST combined blood test and an imaging biomarker. This test was correlated with liver biopsy. First of all, I want to talk about NIS4. It is composed by these different biomarkers. It's the messenger MRI, A2M, YKL40, it is the glycoprotein of inflammation, and hemoglobin A1C. This non-invasive test was developed to identify patients with active NASH and with advanced fibrosis. The data were derived from 2 large database bases. It was the training set from Golden Trial and also the validation set from Resolve-IT trials. And for overall population, the performance of NIS4 to identify patients with active NASH and advanced fibrosis was good, and the area under ROC curve was 0.8 0.83. And also, as you see in this table, this performance was also good for entire clinical spectrum of NAFLD. What about FibroSpect? This is a non-invasive test developed for differentiating patient with NASH and mild fibrosis versus patient with NASH and advanced fibrosis. It is composed by serum A to M, hyaluronic acid, and TEMP1. These parameters were incorporated into an algorithm and developed FibroSpect. This was developed by using a retrospective analysis of serum of patient with biopsy-proven NAFLD with different grades or stages of fibrosis. The performance of this test was validated in two separate large cohort, and the performance was very good because the area under ROC curve was 0.856, and with very good good sensitivity and an excellent negative predictive value. What about ADAPT Pro C3? It is an algorithm based on age, diabetes status, Pro C3. It is a fibrogenesis marker and also platelet counts. This was incorporated into this algorithm, and the data were derived from two large cohort, derivation cohort and validation cohort. Also, ProC3 was a strong predictor of advanced fibrosis and was independently associated with advanced fibrosis because you see here the odds ratio and the p-value. By combining ProC3 with clinical and also biological marker, we generated this new biomarker, ADAPT ProC3, that is a good biomarker for the identification of patient with NASH and advanced fibrosis, because as you see, the area under ROC curve was also very good, 0.86. And now let's move to the last new biomarker. It is FAST. This score is based on fibrosis and steatosis evaluated by using FibroScan, and also with inflammation, estimating by using AST value. And this score was developed using a prospective multicenter study of a patient undergoing liver biopsy for suspected NASH. And this new biomarker was developed for differentiating or for detecting patient with NASH and advanced fibrosis. The performance of this score was very good for this scenario. And as you see, the area under ROC curve was good between 0.82 and 0.93 in the validation set. This score was applied for screening of NAFLD in a real world cohort in San Antonio, enrolled 510 patients with and without liver biopsy. And if you see in this graph, in the blue box, there are patients without NASH on liver biopsy and without fibrosis. And in the red box, there are patients with NASH and advanced fibrosis. And you see here a very nice separation between patients with advanced fibrosis and the patient without fibrosis. And we can, this new biomarker with this new non-invasive score can be used for risk stratification of patients with NAFLD. To optimize the evaluation of liver fibrosis, it was recommended to use this approach, stepwise approach, by use sequential non-invasive test because as you see, by using the first test that can be a simple blood test, there is the gray area between the low and the high cutoff. And if we add the second non-invasive test that can be a specialized test or an imaging test, we can reduce the gray area by half. And now to establish the performance of the sequential combination of non-invasive tests, it was used the data from Stellar trial, and you see here, and that if we use a single test, either NAFLD fibrosis score of FIB4, about 50% or of a patient were in the indeterminate area. But if we add another test like ELF or VCTA, we can reduce the proportion of patient in indeterminate area by half. In conclusion, non-invasive tests should identify which patient in NAFLD require follow-up. AST and ALT are not sensitive for NASH. Alone, FIB4, NAFLD fibrosis score, VCTE lacks sufficient positive predictive value to predict NASH and fibrosis. The sequential use of non-invasive tests maintains sensitivity and specificity and enabling the classification of a larger proportion of patients. Non-invasive tests alone or in combination can be useful for fast identification of NASH progression. Thank you.
Thank you very much, Professor Carmen, for your elegant lecture. And now, my dear professors, commentator, any question from you to Professor Carmen or Professor Islam? Or,
and ask Professor Carmen, please.
Okay.
Professor Anna?
Okay.
Okay. Professor Carmen, thank you for the excellent presentation. I would like to ask you about the intermediate zone. Still, after the whole non-invasive evaluation, still we diagnose the advanced fibrosis. However, we have a problem in the intermediate zone. I think there is no definite drug till now for NASH treatment. And in every drug trial, still liver biopsy is very important for this intermediate zone. What is your opinion?
Yes, I agree with you, but there is a problem. Due to the fact that we don't have an approved medication, the patient do not accept liver biopsy for NASH. And that is why, as now, there are many non-invasive tests that can allow to add medication for viral hepatitis C. This is a very difficult problem. I also think that liver biopsy cannot disappear in the field of the NASH diagnosis, because all the non-invasive tests that we can use and can be on development, I think that they can reduce the number of the patients that need to underwent liver biopsy, but cannot be definitively disappear in the field of hepatology for NAFLD evaluation.
Yes, yes, we can. Okay, thank you.
Any question?
Mona,
nice presentation.
It's only.
Thank you. I'm sorry.
Only a very short comment. Thank you, Professor Carmen. It was a very informative talk. And you took us in this journey, which we know we need to build up a friendly, reliable, and a cost-effective scoring system in order to apply it in our health system. But what I liked most, that you would like to stratify the patient, and you illustrated that the best thing is to illustrate patient, to stratify your patient into low risk, intermediate risk, and high risk. And depending on this stratification, then we can apply either simple biochemical markers, or maybe we can apply CAP or shear elastography. And in those patients with a higher risk, you may spend more money on doing more expensive investigations and so on. So just this was a very short comment, and thank you again for this very informative.
Let me welcome Dr. Zeyad Sharaiha from Jordan and Dr. Salim Awad from Emirates. And we have one more question from Dr. Rida El-Badawi for Dr. Islam. Is the new name MAFLD, will it change the line of treatment? Professor Islam?
So thank you for this good question. So actually at the moment, there is no treatment except a change of lifestyle, which undertake a change of diet pattern and undertaking physical exercise. And unless, yes, there is evidence that if you lose between 7 to 10% of your weight, or you undertake physical exercise, you can have a regression of steatohepatitis and fibrosis, but this is not visible for every single type of patient. So we still need a pharmacological therapy. And as I mentioned to date, there is over than 1,000 clinical trials. 3 of them reached to phase 3. And unfortunately, all of the trials to date either failed or show very poor response, which between 10 to 20% over the CO. So the new definition, it's not only about the new name, it's about the new definition and the new concept. So the new definition wouldn't lead directly to a treatment, but will make the performance of clinical trials better so you can reach for a treatment. So if we look for the trials which are failed, if we stratify this patient and understand which the driver in each single type of patient, then we can choose the correct type of treatment. So in another word, that new definition will shift us from one size fits all, which is the way of working clinical trials at the moment, to more specific or targeted type of therapy.
Okay, now Dr. Maysam is with us. She will, what is new in NAFLD pathogenesis, biomarkers, and treatment? Dr. Maysam? Unmute your microphone to hear you.
Hello.
Hi. Okay.
Good evening, everybody. Can you hear me?
Yes.
Okay. Thank you so much for the Egyptian Society for inviting me for this really fruitful talk. My colleagues had touched upon everything in NAFLD. I will just go through the very quick stuff that was supposed to be before the last lecture. That's why I'm going to go through the basics quickly. Definition of NAFLD is the excess fat content more than 5% of liver weight, and it's usually mainly triglycerides in the absence of excessive alcohol consumption, as we all know. And usually the prevalence increases with obesity and metabolic syndrome or type 2 diabetes. And it's still increasingly diagnosed without type 2 diabetes, as my colleague said, and sometimes without metabolic syndrome. The recurrence of NAFLD, NASH, and liver transplant recipients implicates that there is a pathogenesis in the liver itself, and there are liver-related factors. It's not only due to disease. Some studies had shown that in NAFLD, there is an early predictor for diabetes as well. So it's not always a consequence, it can be an early predictor. And sometimes no one knows whether NAFLD is a cause or predisposing cause for type 2 diabetes or it's a consequence. MAFLD, as my friends had elaborated upon, 22 countries worldwide had defined a new definition that is hepatic steatosis with one of the following 3 criteria: overweight, obesity, type 2 diabetes, or any evidence of metabolic dysregulation. And the exclusion of other chronic liver disease is essential, especially alcohol intake. The prevalence, as everyone had mentioned before, is rising rapidly, and it's more than 20% in the general population in the US. mostly in obese population where it can go up to 92%, and up to 17% of children and adolescents may be affected with NAFLD as well, where in our area, the Middle East, unfortunately, despite all the healthy foods, we have the highest prevalence up to 32%, like South America, while in Africa, it goes down to 14%, which is the lowest prevalence worldwide. And the studies with a small sample size have suggested that progression to liver cirrhosis can be found in as high as 25%. Can you concentrate with me? In the era of eradicating hepatitis C, NAFLD now took the top of the list cause for liver transplant, people queuing in the world for transplant. This very traditional picture that we all know goes from normal liver to simple steatosis, steatohepatitis, ending up with cirrhosis and sometimes hepatocellular carcinoma, is now not only through steatohepatitis, but it rings a bell that hepatocellular carcinoma can occur even with simple steatosis without going through NASH and cirrhosis. Please, let's pay attention to simple steatosis that might end up with hepatocellular carcinoma in 0.5%, even without going through the natural process of steatohepatitis and cirrhosis. The theories two hit hypothesis. The first is an imbalance of fatty acid metabolism that leads to a high hypertriglyceride accumulation and causing steatosis, and also the oxidative or metabolic stress and dysregulated cytokines due to altered lipid homeostasis. They can lead to subsequently inflammation and fibrosis. So the data show that hepatic mitochondrial dysfunction is crucial in the pathogenesis of NAFLD. The whole thing goes around 3 decades ago when Dr. Ludwig identified NASH as fatty changes with lobular hepatitis with no alcoholism. And the main histopathological finding was the chicken wire in zone 3. And this is the first thing that we should look for in histopathology in the slide. The Mallory-Denk bodies can be highlighted by P62 or ubiquitin immunostains as well. Loss of keratin 8 and 18 immunostaining has been shown in the ballooned hepatocytes of patients with NASH. And this finding is not specific, but can be also seen in alcoholic steatohepatitis, cholestasis, and ischemia. So we have to differentiate from the history and physical examination and all the blood tests between simple steatohepatitis, and that is secondary due to other pathologies. Not to forget about sudden weight loss following bariatric surgery, malnutrition and acute starvation, TPN, and all the congenital syndromes from hypobeta-lipoproteinemia, tyrosinemia, galactosemia, and all the toxins and medications that can hurt the liver. One of the very important theories is gut microbiota that produces lipopolysaccharides. They may sensitize the liver to tumor necrosis factor and leading to hepatotoxicity. Everyone talked about the imaging, the ultrasound, the routine ultrasound that we all know about, but we all know that FibroScan is now more sensitive and can give us a better clue about fibrosis, not only whether we have the ballooning and the fat in the liver, but we can quantitatively do some assessment of steatosis and fibrosis. And it's accurate and reproducible, and it samples more than 1/500 of the liver, opposite to the biopsy, which samples only 1/50,000 of the liver. So the biomarkers had been mentioned by my colleague, but we'll go through the very quick ones. Abnormal liver function test, but we just said that AST and ALT are non-specific markers. The markers of apoptosis, cytokeratin 18, adipokines, the main adipokines and cytokines involved in the pathogenesis of NAFLD include adiponectin, leptin, resistin, and visvatin. Ghrelin is a 28 amino acid peptide levels correlate negatively with insulin resistance. And also the RBP4, which is another adipokine associated with insulin resistance, were also higher in NAFLD patients compared to controls. Cytokines and inflammatory markers, also interleukin-6 and high sensitive CRP. They have a great role as biomarkers, and they give us a clue about fibrosis. MicroRNAs are implicated in the pathogenesis of NAFLD. However, more research is required to validate their usefulness as diagnostic or prognostic markers. Exosomes and ectosomes, they contain various cellular molecules like proteins, mRNA, miRNAs, and DNA. They can serve as biomarkers in NAFLD and NASH. And also it's better excluding advanced fibrosis and cirrhosis rather than accurately diagnosing fibrosis stage for these biomarkers, all of them. Procollagen C3 levels, they permit to discriminate between patients with or without histological diagnosis of NASH and a relatively linear relationship with the grade of NASH. The more they are and the more severe the grade of NASH. Also in NAFLD, it's a complex disease trait with relevant interactions between genetics and environments. They found some genetic variants that are more in patients with steatohepatitis, like the RS738409 and the RS58542926 identified in certain patients. Despite the important impact of these genetic variants, discoveries specific DNA sequence variation, including single nucleotide polymorphism, identified in individuals at risk of NAFLD. There is that NASH test combines 3 biochemical markers, starting with the age, sex, height, weight, and serum levels of triglycerides, cholesterol, and macroglobulin, apolipoprotein, haptoglobin, gamma GT, ALT, and AST, and total bilirubin to predict the presence or absence of NASH. That we do usually once every 3 years for these markers and calculations. More recently, a validated serum test to differentiate mild to moderate fibrosis from the advanced fibrosis, utilizing concentrations of alpha-2 macroglobulin and hyaluronic acid and TIMP1 proteins. It identifies patients with high specificity and sensitivity at the predetermined cutoff score of 17. We know about the MRIs, and we know MRI estimated proton density fat fraction is the most accurate test now to use to quantify hepatic steatosis and can be considered the gold standard because MRE is less available and more expensive. Plasma cytokine 18 fragment levels are a marker of hepatocyte apoptosis and represent the most extensively evaluated biomarker for steatohepatitis, although the accuracy is still modest. We know all these scores, and my colleagues went through most of them, that rely on different variables and assess the level of fibrosis, starting from the AST-ALT ratio, the platelet ratio index, the BAT and the BARD and the ELF. ELF is the commonest usually to be used, and the NAFLD fibrosis, where you do all the variants and do the calculations to decide whether your patient is in an early F0, F1, F2, or a late F3, F4 stage of fibrosis. I want to concentrate on iron, which is very important contribute to the hepatic inflammation and carcinogenesis. Iron overload may lead to advanced hepatic fibrosis, and also it may be significantly seen among patients with HCC NASH versus NASH alone. So the risk of iron, especially in those with insulin resistance, it's usually directly mediate iron overload, and it's associated with the risk of hepatocellular carcinoma. How to manage? We all know that lifestyle is still, until now, the golden stone and the cornerstone and the golden rule in treating NAFLD. And these people should not consume alcohol. And there is not a single medication on earth that until now can help these patients. If your patient is diabetic with insulin resistance, metformin will be really good. Other rosiglitazone and it's a group from the oral diabetic medication can help as well, and they do help in affecting less fibrosis progress in these patients. You know about glucagon-like peptide. الصرعة الحالية في الأسواق هو Saxenda. The medication people use to block the appetite and decrease their weight and sensitize the body to the insulin is playing a good role in helping in animal models in NAFLD disease and decreasing the liver enzymes as well, affecting the histology of the liver. Also, SGLT2 inhibitors, they have a good role in controlling, and there are meta-analysis studies that showed the effect of these medications on NAFLD, and they all included studies noted in a significant improvement in AST and ALT. Statins, we know that statins carry a very essential role in controlling NAFLD. People sometimes, when they see the liver enzymes high, they deprive their patients from having statins to treat their high lipids, which might be the underlying cause of steatohepatitis rather than being a cause of elevating the enzymes. So statins are really essential, and they help against HCC. Vitamin E only in non-diabetic adults can give some help. Otherwise, it's of no proven value. Omega-3, when the triglycerides are high, you can use it. But please remember coffee. Coffee, in many studies, had shown its effect on NAFLD and on cirrhosis and hepatitis C liver fibrosis. So coffee had a good effect on reversing fibrosis and changing the histopathology. There are studies that showed coffee has been reported to slow disease progression in alcoholic cirrhosis, hepatitis C, and NAFLD as well. The new medication, the CCR2, CCR5 receptor antagonist blocker, which is Cenicriviroc, and this medication is being studied on HIV as well, showed a very potent effect in reversing fibrosis, and overall has shown favorable safety and tolerability profile in more than 1,200 subjects, including those with cirrhosis and hepatic impairment. And this is one of the 3 immune modulator medications under study now for COVID-19 treatment with Remicade and Ornicia. What we need to know is, usually we don't screen for NAFLD unless we have children with type 2 diabetes, we do screen, and lifestyle modification is the only evidence-based management. Offer adults with NAFLD a screening for advanced liver fibrosis with the ELF blood test every 3 years only. Offer children with NAFLD screening for advanced liver fibrosis every 2 years using the ELF blood test. Remember vitamin D and its effect and positive influence in these patients, statins and their importance in decreasing steatohepatitis. Remember, obstructive sleep apnea can increase the hypoxia on the liver and add on the disease. and check for low T4. Thyroxine is essential for the liver. Remember the non-obese fatty liver disease, NAFLD, and remember the non-obese steatohepatitis. It's not always the disease of obese people, and the treatment can go from weight reduction, controlling other diseases, having bariatric surgery, and treating the gut microbiota as well. And thank you so much.
Thank you, Dr. Maisa, for the elegant presentation. And we now proceed further for the lack of time. As we know, many drugs are in the pipelines for treatment of NAFLD. One of the drugs with promising antifibrotic effect in phase 3 trial is the obticholic acid. My dear Professor Fatma Murad, Hepatogastroenterology, Azhar University, will tell us obticholic acid for NASH, a revolution or just a rep. Dr. Fatma.
Thank you, Mona. You hear me?
Yes.
Yes, okay. I would like first to thank Professor Serag and Professor Baddar and the organizing committee for this nice invitation, as well as I thank Professor, my colleague Mona, for the arrangement of this wonderful session. Now we will jump to the treatment. Actually, just a minute.
Can you share your from
yes.
your side, or you present it here?
Yes. Okay. Actually, as Professor Islam said and Professor Maisam said, there is no actual treatment. The treatment is non-specific, not related to the pathogenesis, which we are not aware of completely. But the trial of treatment is going on all the time. So we will jump to the treatment now with the obticholic acid, which is a first in a class, specific and selective for the FX receptor agonist with anti-cholestatic and hepatoprotective properties. The obticholic acid is a 6-A-ethyl selective derivative. This is the additive of the normal chenodoxycholic acid, which is a primary human bile acid derivative. And the chemical modification stimulates the phenylacetic receptor, the FX receptor activity. The FX receptor is apart from the bile acid receptors. The activity is more than 100-fold intensity than the chenodoxycholic acid, which is a natural FX receptor agonist in the human, and show also selectivity and minimal activity on the other bile acid receptor. This is the acylation, the acyl substitution, which increase the potency by almost 100-fold. FX receptor itself is a nuclear receptor which is expressed in the liver, intestine, adrenal glands, and the kidneys. It modulates the tissue metalloproteinase inhibitor 1 and the matrix metalloprotease expression in the hepatic satellite. So it has an effect on the hepatic satellites, which is responsible for the liver fibrosis, and promote resolution of liver fibrosis, and activation of the receptor can lead to reduce the hepatic fibrosis and inflammation. FX receptor regulate also the lipid and the glucose metabolism through a complex pathway involving multiple target genes, cytochromes, and enzymes, but ultimately with activated it convert the cholesterol into bile acid, put the glucose into storage, and reduce the fat storage. So the activation will lead to suppression of the cholesterol 7-alpha hydroxylase, inhibition of the bile acid secretion, regulates the hepatic triglycerides, suppress the lipogenesis, and promotes free fatty acid oxidation. Obticholic acid administration with orcidiol or as immunotherapy for 12 months in patients with primary biliary cholangitis result in decrease from the baseline in alkaline phosphatase and the total bilirubin that differ significantly from the changes observed with the placebo arm. So the obticholic acid now approved by the FDA as a mono drug for the management of primary biliary cholangitis in 2017. Obticholic acid is currently, it is not approved by the FDA till now, but it is currently the only investigational therapy to receive a breakthrough therapy designation from FDA for the use in NASH and has uniquely demonstrated reproducible ability to reverse and otherwise stabilize the liver fibrosis. Yani can improve the liver fibrosis and reverse it or even stabilize the stage of fibrosis in patients with NASH. Multiple longitudinal studies have been shown before that fibrosis is the only histologic features that predict the mortality and the morbidity in NASH patients. So if you you have a drug to affect this fibrosis, you are in the right stage. Thus, stabilization and the reversal of fibrosis are the paramount for the drug to be considered successful. Between December 2015 and October 2019, almost 2,000 patients with stage 1 to 4 to 3, from F1 to F3 fibrosis were enrolled and received at least one dose of study treatment. The patients were divided into 3 groups. One received 25 milligrams per day of obticholic acid, and one received 10, and the other group received 10 milligrams obticholic acid per day, and placebo arm. The this was a multi-center randomized placebo-controlled trial demonstrated that obticholic acid led to histological improvement in NASH. This is phase 3 of the most popular 3 drugs, and the obticholic acid improvement in the endpoint, yani primary endpoint, because the study was well extended over 6 years. Improved in NASH and without worsening of the fibrosis. So this study is conducted for 6 years with the 3 arms, as I said before. So the effect after 24 months therapy, there was changes in the baseline ALT, AST, and gamma glutamyl transferase as the serum marker of fibrosis, FIB4, and the AST platelet ratio, and the liver stiffness by the FibroScan. There is improvement in histologic fibrosis by 1 stage in a group of fibrosis from stage 2 to stage 1 and from stage 3 to stage 2 in a good number of patients with a statistical significant than the placebo arm. The side effect was pruritus, which was related to the dose, and it was dose dependent. It only occurred in the patient with 25 milligrams per day, with only about 9% of the patient received 25 milligrams. They had to stop the treatment because of the pruritus. In the 10 milligram group, there was less than 1% of the patient who can stop treatment because of pruritus. Also, there is increase in the LDL, which was treated by statin in the high risk group for the increasement of LDL. So, despite the improvement in liver fibrosis, still FDA did not feel that the existing data demonstrate adequate benefit to outweigh the potential risk and the importance of the long-term outcome. This decision not only is a step back to the pharmaceutical, the Intercept, the pharmaceutical company which is responsible for the obticolic acid improvement or development, but also send a message to other pharmaceutical companies with the therapeutic agents in development that there will be a high bar for the surrogate endpoint to gain FDA approval. Patients with significant fibrosis have limited options, and the obticolic acid, if approved, could become a breakthrough to our fight toward improvement outcome in NASH. It remains to be seen whether it will be a remedy for millions affected by NASH or an additive therapy that doesn't take the place of lifestyle intervention, but nonetheless get us one step closer to our ultimate treatment goal. This is the only drug available, if approved, had a pathogenesis understanding. And thank you for your attention.
Thank you very much, Professor Fatma, for the elegant lecture. And I think this is one near to be FDA approved for the treatment of NASH. This is the nearest one to be approved. Now we near to finish last speaker. And as we are in the era of the current pandemic of COVID-19 and due to high prevalence of NAFLD in the general population, we need to know whether this patient at higher risk of COVID-19 or not. My dear friend from Mayo Clinic Division of Hepatogastroenterology, Professor Denise Harnois, will illustrate this issue. Welcome, Professor Denise. Floor for you.
Thank you very much, and Assalamu alaikum. I appreciate the opportunity. Are you able to see my slides that I'm sharing now?
Yes, yes.
Okay, good. Sorry, it looks different on my screen. I want to thank you very much. I'm very honored for the opportunity to speak, and I thank you, Professor Mohamed, for the invitation. I'm only sorry that I won't be able to be there in person to visit your lovely country, and hope that maybe sometime in the future that I'll be able to. So my talk today is on the issue of looking at whether or not these patients with metabolic associated or non-alcoholic steatohepatitis, fatty liver disease, are at increased risk of complications of COVID-19. And I'm humbled by presenting this presentation, as Professor Amin had actually published on this very topic from the European Journal of Gastroenterology and Hepatology fairly recently. So let's just talk a moment first about the issue of epidemiology. So of course, the novel coronavirus was discovered in the late 2019, but it was on March 12th, 2020 that the World Health Organization declared this coronavirus, now called COVID-19, as a pandemic. Most coronaviruses, as we can see here, are actually causing only the common cold, but several have been identified as causing more substantial disease, the severe acute respiratory syndrome, SARS, in 2002, 2003, and then more recently, the Middle East respiratory syndrome in 2012, still present today, which has a higher mortality rate than what we're seeing by the current coronavirus, but appears to be less infectious. So this coronavirus, called the severe acute respiratory syndrome virus 2, the disease being called coronavirus because it was in 2019, then the definition of COVID-19. When we look at a publication from Lancet early in the epidemic in March of 2020, what we see was a discussion in terms of what the vulnerability would be for Egypt and some of the other African-related countries, which largely was related to their potential in terms of the numbers of people who seem to be going back and forth to the issue of China. And we can see that Egypt was one of the areas in which modeling had demonstrated would likely be potentially very vulnerable to the infection. The first case that was seen in Egypt was February 14th. And you can see here that it was relatively small number of cases with an uptick that then happened around mid-March. And you can see the green line represents the uptick that happened in Egypt. When we look at simulated versus observed predictive models for the COVID-19, some countries have been able to sort of more flatten the actual observed over what was predicted to be potential and stay a relatively low number of cases. Early on in the pandemic, Egypt, the original observed versus expected was more paralleling a more significant number of infections. If we look globally now, this initial slide was put together only not even a month ago when we had 27 million cases. As of yesterday, it's now 41.5 million cases, accounting for more than 1.14 deaths within the world. Talking just a moment about virology and transmission. So we're very familiar with seeing this picture of the RNA virus of the coronavirus. It is the spike proteins that allow the virus to attach and fuse into the cell membrane. The attachment seems to happen through these angiotensin converting receptors, and this is important in terms of its implication with liver disease. The transmission we know is generally person to person through close contact. It now appears clear that there's both a transmission in terms of droplets and also airborne potential transmission. Because these particles can remain in the air for a period of time, perhaps longer when the environment is more humid and colder. Infected surfaces, thought to be initially much more of an issue early on in the pandemic, appears to be probably a little bit less of an issue now. The virus can be found in other secretions, but the role of transmission there is not quite as clear. Animals, including domesticated animals, have a potential source of infection, but don't appear to be playing a major role. It also has become clear that about 10% of people probably account for 80% of the transmissions. These people that have very high viral loads in their upper respiratory tracts appear to be the ones who are most infectious and causing what we call in the United States these sort of super spreader type of incidences that occur. The other problematic thing about this virus is that modeling suggests that more than 50% of people who are infectious actually have no symptoms, particularly at the time they might be most infectious. And so controlling it based on symptom management and isolation has been very complex. How do these patients generally present? Well, the vast majority of the incubation period appears to be a range of about 2 to 14 days, but most will end up developing symptoms within 4 to 5 days of the incubation and exposure. The symptoms we're all very aware of. They generally present with fever. The vast majority of people will have a fever, cough, shortness of breath, but other less specific syndromes like sore throat, headaches, diarrhea. Some recent studies have demonstrated that patients who present with diarrhea are more likely to have a more severe form of the COVID infection. So that's something to watch out for in terms of presentations. It seems to have a very wide spectrum of disease. The vast majority of people will have a fairly mild or moderate presentation, but there are a percentage of people who will have a more severe presentation of the virus and those who will end up as critically ill or have a mortality. Overall, the case fatality rate seems to be about 2.3%. And this is important when we look at the comparison of this rate versus what we're seeing in patients with chronic liver disease, and more specifically with the issue of fatty liver disease. What are the manifestations? The largest, of course, is this acute respiratory distress syndrome, but these patients can get hyperinflammation, have multi-system implications, including neurologic disorders. They have a hypercoagulability, which leads to thrombosis, and particularly in children, a multi-system inflammatory syndrome that can develop. Not all people appear to be at risk equally for the more severe forms of the illness. Older adults and those with underlying medical conditions most at risk. In the United States data that's demonstrated here, people who are in their older ages are the ones who appear to be most at risk for hospitalizations. and those with underlying medical conditions. The one that we want to focus on most specifically in this talk are the risk associated with those people who have diabetes and those people who have obesity, defined as BMIs over 30, with a lower BMI designation for those who are Asian. And liver disease is also one of the medical conditions that's been identified as increasing the risk for more severe illness. So let's talk specifically about this issue of COVID-19 and its impact on liver disease. So we know from studies that have been done that hepatic dysfunction is very common in those individuals who are exposed to the virus. A meta-analysis looking at 15,000 patients showed that a quarter of them would have elevated liver tests somewhat throughout the course of their illness. It's less in people who have milder cases than in those that have the more severe cases, where almost up to 50% of people will have abnormal LFTs. Those who are in intensive care units are more likely to have abnormal LFTs than those who are not in intensive care units. And this is likely multifactorial. We'll speak more about that in a moment. What's interesting is that the elevation is actually more common in AST and ALT than in cholestasis, because the bile ducts actually themselves have these angiotensin converting enzyme receptors. So you would expect that this would be a disease that would cause more cholestasis than necessarily transaminase elevations, but appears to be causing more of a lobular inflammation and hepatitis, resulting in an increase in AST and ALT more than in an increase in terms of cholestatic disease. And in about 5% of people, there have been documented cases of acute liver injury. So when we look at the issues to do with liver disease, it does appear that patients with liver disease have a higher risk of fatality and of decompensation if they have cirrhosis. The mortality rate seems to be about 14% for people that have chronic liver disease. The more decompensated their liver disease, the more risk associated with it. Those with B and C child's cirrhosis being the most at risk for further decompensation and increased mortality rates. Most of the studies have demonstrated the group that appears to be the most at risk with chronic liver disease for having these complications is those with metabolic associated liver disease. There was a very recent publication of US data looking at about 900 patients. It's available only in its preliminary forms, but that seems to show that in the US, alcohol-related liver disease is a particularly significant risk factor for decompensation and mortality. So how does the virus impact the issues related to the liver? So the virus has its predominant impact in terms of issues to do with respiratory failure, but it can cause hypoxemia there and venous congestion. This leads to the potential of liver injury. There is viral shedding in the GI tract. There is also the fact that we can have, as I was discussing, this issue related to decompensation from liver diseases causing further liver failure. There's interleukin-6 release and cytokines, which can alter the coagulation balance and impact the liver. There's issues related to immune cells and cytokine, what they sort of call the cytokine storm, that also seems to be contributing to some of the liver injury that we're seeing. And then the drugs that we're using themselves, particularly some of the antivirals, have some potential of effects on the liver as well. One thing that's very important, though, is that these antiviral therapies can also reactivate hepatitis B, or that all patients who have COVID-19 shouldn't be assumed to necessarily have elevated liver tests exclusively from the COVID virus. And so we need to exclude other potential etiologies, particularly etiologies related to viral hepatitis that could be causing worsening of these liver tests. So when we look specifically at this issue to do with non-alcoholic or metabolic associated liver disease, we know that patients who have higher BMIs are at increased risk for more severe forms of COVID. These ACE2 receptors are seen in the adipose tissue, and so this may be one of the mechanisms that's driving this. These patients do appear to have longer viral shedding, and so that might be one of the things that's impacting what we're seeing in terms of decompensation. But a number of studies have demonstrated that these patients are at risk for more severe disease than those patients who have other forms of chronic liver disease or have no evidence of liver disease. And it does not appear to be just the older patients that seem to have this. We're seeing that in younger patients who have metabolic associated fatty liver disease, they are also at increased risk for more severe forms of the COVID illness. A multi-center preliminary analysis that was done and published in Journal of Hepatology demonstrated that when they looked at age, and they did a sub-analysis of anywhere from 55 to 65, but in those less than 60 years of age, metabolic associated fatty liver disease, which was defined by having risk factors and also CT scan evidence of steatosis, that in a multivariate analysis in younger patients, this was associated with a more severe form of disease, even when they accounted for issues related to age. We know that men appear to be more at risk for severe forms of COVID than women, even when they accounted for diabetes, obesity, and smoking. What they found was that younger patients with metabolic associated fatty liver disease had a threefold higher likelihood of having more severe disease. In addition, what we're finding is that a number of these patients who had abnormal liver tests around the time when they had their illness, about a third of them seem to be persisting even after the time when the illness has resolved. And so what that will mean long-term in terms of the issues related to liver complications from COVID-19, I don't think we yet really clearly understand. So in answer to the question, do patients with non-alcoholic or metabolic associated fatty liver disease have a higher risk of more severe complications from COVID-19? I think the answer is yes. I think a lot of the data focuses in the Asian population, which may be different than what we see in the European, Middle Eastern, African, and also US populations. And I think that more data is needed to really more completely understand this. But I think we do need to be careful in these patients who present who do have fatty liver disease, that they are going to be at higher risk for complications, even those individuals that are younger. And I thank you very much for the opportunity to present this information today. Thank you.
Thank you very much for the elegant presentation and for your time and the presentation here. Now we have few minutes for discussion with our expert. Any questions for any of our speakers?
Professor Mona?
Yes.
Can I ask Professor Mayasem?
Okay, sure.
Okay. Professor Mayasem, thank you very much for the elegant presentation. You discussed all the issue about the pathogenesis. I have only one question about the platelets. As platelet activation have a role in NASH progression, did you think that use of antiplatelet could be effective in this situation to prevent the progression, especially to prevent hepatocellular carcinoma in those patients?
Actually, it was not mentioned in the literature, but I believe these patients are usually having other comorbid illnesses that will end up hurting them more, like ischemic heart disease and hypertension. And these patients are usually on aspirin because of the obesity, type 2 diabetes. So I believe they are already on antiplatelets as part of their treatment regimes. It's worth being studied as a point to see if antiplatelets can help patients with NAFLD and if they have steatohepatitis, if it prevents progression or controls the progress to hepatocellular carcinoma. But I believe it's a co-factor and a comorbidity that these patients are usually on aspirin.
Any more questions?
Can I go back to Professor Islam, Dr. Ramona?
Professor Islam, are you still there?
Yeah, sure. Yeah.
Professor Islam, my question is, the good thing about MAFLD that they included inflammatory markers, and they considered inflammation again as an important factor which may affect the outcome in patients with MAFLD. And they consider C-reactive protein one of these inflammatory markers. And I heard from Professor Mayasem that ferritin or iron has a deleterious effect on the liver and it could be considered as an inflammatory marker. So in your own opinion, do you consider C-reactive protein, which I understand that it's not a specific marker, do you consider this an accurate marker to be included in monitoring patients with MAFLD, or you're thinking of other markers which could be more accurate, such as microbiota signatures or others. So what's your opinion, please?
Yeah, that's really so good questions. So I guess we just need to distinguish between 2 points. Establish of diagnosis, you know, like your patient have fatty liver disease, and then stratification of the severity, as you mentioned, is it high risk or low risk or intermediate risk? So establishment of the diagnosis, this algorithm we have made to replace the negative definition, which was based on exclusion. So till we propose this definition, we don't have any way to diagnose fatty liver disease. It's just by the exclusion of other liver diseases. So once you establish the diagnosis, so all what the other colleagues have mentioned are tools we can use it for the stratification of the severity of patient. And so far, we don't have the perfect tool for stratification of our patient, but we think that in the near future, we will have more accurate markers for them.
Thank you.
I just want to comment, if there's time, Professor Mona, on the talk of Professor Murad. It's very fantastic talk on the obtocolic acids. It happened that I wrote the editorial in Lancet for this study, and I just want to clarify for the audience few points here. So now the approval of any drug for NAFLD, it is divided into 2 stages: conditional approval and then confirmed or firm approval. So for the conditional approval, you have to meet one of 2 endpoints: improvement of fibrosis by 1 or 2 stages, and or improvement of steatohepatitis or NASH without worsening of fibrosis. When we look for the, first of all, we just need to make it clear for our all audiences that FDA rejected to approve the obtocolic acid. So it's not now we are waiting for the approval. No, it's already applied last year, and the rejection happened like 1 or 2 months ago. And the reason for this, 2 or 3 multiple reasons for this. The first one, yes, it's the first trial to show some positive response, but it only happens on fibrosis. There is no response or effect happens on improvement of steatohepatitis. And this is actually one of the reasons we think that the dichotomization into steatosis and NASH, it has a lot of problems and it affecting the clinical trials. And this is one of the classic examples. FDA used this as a reason for the rejection of the approval. The second reason for the rejection, that one of the side effects happens from the drug, it increased low density lipoprotein cholesterol by more than 20%. And one of my colleagues in Germany, John Schattenberg, he did a modeling and he found that this increase in LDL will increase the cardiovascular mortality by 8%. So the benefit you will get on the liver will be blunted by the side effects on the cardiovascular risk. And if you know that your patient, the main cause of this is the cardiovascular, so the net effect for your patient, if you are treating a patient, not an organ, will not be for the positive for the patient. On this basis, FDA decided to decline the approval of this drug.
Thank you very much. And for the sake of time, let me sum it up and close this session. The proposed change of the name from NAFLD to MAFLD hold promise to aid in increasing awareness of this liver disease and decreasing its possible social stigma due to its link to alcohol intake. And many drugs now are in the pipelines of different stages of development. So we need a biomarker and non-invasive test with high predictive and negative predictive and positive predictive for assessment of high-risk patient to diagnose them for treatment in the future. Remember that the most common cause of death in these patients is cardiovascular disease, and you have to manage the patient as a whole and modify the other risk factors such as diabetes, hypercholesterolemia, and hypertension to improve the survival of these patients. And finally, I am thankful for all my guest speakers and my dear commentators for their cooperations and organization of this session, and thank you all for your attendance.
Thank you. Thank you.